early cervical cancer. Para dar continuidade, convidar o professor Fabrice Lecuru para nos falar sobre o Senticol.
Good morning, everyone. It's a real pleasure to be here. It's my second time in Brazil, and it's a second time of pleasure. Yesterday, we had a wonderful day with a lot of very interesting propositions of research, and it was a very good surprise, I said, Remy, just before. And your society is really wonderful. It's really dynamic. You have really motivated, and it's a real pleasure to see you. I will just say a few words on the Senticol-free story and what we can say today about SLN in cervical cancer. I will introduce my presentation with the conclusion of Mary. We are complicating the management of early cervical cancer. Just remember that 30 years ago, we had one operation for all patients. Radical hysterectomy by either 2 or 3, and pelvic lymphadenectomy and maybe para-aortic for some people. And it was for all the patients. And now we are very more precise in the indications, in the definitions of subtypes, less than 2 centimeters, less than 1, LVSI, no LVSI, cone positive, cone negative, and so and so, fertility sparing surgery. All these subtypes have much complicated the management of the patients. But we had also made a great de-escalation in the surgical aggressiveness. Radical hysterectomy is clearly effective, but it's really heavy for the patients in terms of subsequent morbidity. And we have de-escalated as the shape, and we are de-escalating also for the nodes, because we know that the nodes are very important for assessment of the prognosis of this patient and to tailor the adjuvant treatment. We also know that today, with the methods of imaging we have, especially MRI, we can eliminate almost all the patients with macroscopic nodal extension. So we will have only very small disease in the nodes, so there is few patients. And we know that removing 20 or 25 nodes just to find one positive node with a small deposit of 2 or 3 millimeters, it's a very bad option. So SLN is clearly, in theory, a very good option for these patients. We had started our experience with sentinel nodes in cervical cancer in 2000. And we had published some papers, and we had made a first trial, which was called Senticol 1, and we assessed the diagnostic accuracy of the technique. We wanted to be sure that the negative predictive value would be very high. And the Senticol 1 trial confirmed the very good sensitivity and the very good negative predictive value of the technique, especially for patients with bilateral detection. But in 2014, we had no other information. We had no accurate information for morbidity. Senticol 2 was only ongoing, and we had no information about survival. And survival is the main endpoint for all surgical technique in gynecologic oncology. So when at the end of cervical cancer brainstorming session in Melbourne in 2014, they asked us to develop a validation trial. We had to validate the survival of the patients having only sentinel nodes. Our first vision was to change the rule and not to do a randomized trial. So we had several discussions, and we opted for comparisons of cohorts. Again, there were some reasons at this time. Some surgeons were convinced of the interest of sentinel nodes, but some surgeons were not convinced at all and wanted to do lymphadenectomy. So we could have centers with SLN and centers with lymphadenectomy. So it appears to us a very good option, but in fact, it's impossible to have a grant, to have a funding with this kind of design. And the GCIG which was a very important partner in this trial, was also against this design. So we moved to classical randomized trial. All the patients had SLN because we were 2 years after 2014, and SLN was spreading in the minds of surgeons, and it was impossible not to offer SLN to all the patients. So patients had first SLN, and if the frozen section was negative, we can randomize between SLN only and SLN plus pelvic lymphadenectomy. And the main objective was a co-primary with DFS, of course, and also quality of life and morbidity. And the hypothesis was that survival would be similar between SLN and lymphadenectomy, and that morbidity, of course, should be decreased. This is a final schema with, on the left, randomization, but also a special arm for patients with positive frozen section. We have no prospective data for these patients. We don't know their real prognosis. We have very strong indications of a poor prognosis of patients with micrometastasis and maybe ITC, but we have no definitive conclusions. So it was, for us, important to add this arm in the trial. Cervical cancer is a global disease, and it's mainly present in a country with low and middle income resources. So we wanted to have a global trial, and we had a global trial. We had centers in Japan, in India, we had centers also in China, in Brazil, and you will see that we were very important in this trial. In North America with Mari, and of course several countries in Europe. The Senticol free story has been a very long story. 2014 decision to make a trial, and we will have the final results, I hope, in 2027. For 13 years of work just to answer one question. It's clearly a too long time, and we should, I think, address this question to our politicians. We make new regulations every year for clinical research, and we should explain them that limiting the possibilities of clinical research is not a protection for the patients. How many patients have died of cervical cancer in the time? Too many. The study status briefly, at the end we had about 90 sites, and we randomized 990 patients between 2018 and 2024. The total duration of a trial will be 11 years for inclusion, and we will have to wait for the final follow-up, which could be in 2029, but I hope that we will have the final results before. As I said before, we have a global trial, but clearly all the countries did not have the same impact. In France, we have the most important number of inclusions, but we started before all the other countries. But as you can see, Lacoy and Brazil was also very strong in the inclusion, and again, thanks to you. The curve of inclusion with, as for shape, a very slow accrual at the beginning of the trial, and the inclusions were faster and were most numbered at the end of a trial between 2021 and 2024. We have to be patient with surgical trial. The statistical plan, I won't describe all this slide, but just imagine that when you take so big trial, you will have a lot of statistical analysis to it to make at the end, and it will be a very big discussion with statisticians, because we have our clinicians' visions, but they have their statistician vision, and we have to make a bargain between the two requirements. We made an interim analysis last year just to check if we had done the good inclusions and if the patients were as expected, and if the operations were as expected, and if there was no negative signal, especially for survival. You have the main prognostic indicators for these patients, and as you can see, it was well balanced between the two arms, especially for age, for ECOG, for LVSI, but you also see that there were very numerous missing patients, missing LVSI information for patients. The histological type was also very well balanced, and the method of diagnosis was also very well balanced between the two arms. No discussion, and we included patients according to the inclusion criteria. It was really early cervical cancer, less than 4 centimeters, only classical histology, and so on, so on, so on. Now survival, and we had a good news. Survival was similar between the two arms, so clearly there is no detrimental effect with this follow-up between SLN only and SLN plus lymphadenectomy. But we have not all the events to make accurate analysis. These results have been made with 43 events, and we will need at the end 136 events. So it was a very small number of events. We hope that the events will occur between now and the 2 next years, because it was in accord with the inclusion curves, and we will have a definitive answer within 2 years. About morbidity, we had several informations. I won't detail everything. There were not so much difference between the two arms. Again, it was also a little bit the same information in the Senticol 2 trial. In the Senticol 2 trial, there were 2 main conclusions. The first is when lymphatic morbidity is frequent even with SLN, 40% of patients, but it's significantly less frequent with SLN when compared to lymphadenectomy. And we have very similar results for the morbidity and for the quality of life analysis in this trial. We have 2 similar trials published today. The first was Sentix. It's a single-arm trial published by David Cibula. Inclusion criteria are the same as for Senticol 3. And it was the results were compared with ferric hypothesis, and the results were good. There was no decrease in the survival of these patients with SLN only. There is also a second trial which have been presented 2 times this year in SGO and in ASCO, but it's not published as a paper today. Inclusion criteria were different with a smaller tumor because the high cutoff was at 3 centimeters, not 4. There was a randomization between SLN and SLN plus PLN. It was a Chinese trial. And the final results were good because survival was similar between SLN and lymphadenectomy. But I think that there are some limitations in this trial. The first, it's only in China. It's not a global study. The second, we have no information about quality of life. And the main limitation is that 50% of patients had adjuvant treatment despite small tumors and negative nodes. We don't understand what were the indications of adjuvant treatment in this trial, but clearly it has an impact on the survival analysis. So, without GCIG and CCRN, Senticol 3 would have not existed. And so thanks to them, thanks to the Genico group, who had been a very strong partner in this trial, as the CHU of Besançon, and all the groups and centers, and especially you in Brazil, you have been very, very, very important in this trial. You joined us very early in the history of the trial, and you have a very large input in terms of inclusions. I want also to thank all the patients and families. My conclusion, 50 years between the first publication about SLN and the final results for cervical cancer is clearly a too long time. We know now several things about SLN in early cervical cancer. It's not deleterious, it's fusible, it's reproducible, it's sensitive, there is an added anatomic interest, there is less morbidity, probably similar survival. We have to wait a little bit, maybe 2 years or maybe 2 years to have a final result. So thank you for your attention.
Thank you, Professor Fabrice. And agora